pneumonia, central line associated bloodstream infection, C. difficile, and catheter associated urinary tract infection forms the commonest. In pediatrics, the commonest which we see will be a ventilator associated pneumonia and central line associated bloodstream infection, especially so in an oncology setup. So, what happens closer home? A small analysis done in Bangalore has looked at the health economics in over 7 years in a tertiary care center. So it says that the escalation of cost due to infection was $4,600, or which translates to approximately 3.5 lakhs. The mortality, which is seen, is to the tune of 8.75% in contrast to 2.5 in the non-infected group. And the mortality due to a central line associated infection or ventilator associated pneumonia was nearly 30%. And similarly, the length of stay in an intensive care unit was 8 days in patients with a hospital acquired sepsis, vis-a-vis just 2.27 days in patients who do not get it. And the length of stay in hospital went up to more than a month versus just 10 days in patients who were escaped having a hospital acquired sepsis. So, essentially, there are a few things which we all need to understand. Basic infection control concepts. Why do we get a nosocomial infection? Understand what are the components of an infection control program. We keep talking about it, reading about it, but what exactly is an infection control program? And to understand how the infection control committee and the drugs and therapeutic committee, which are there in most large hospitals, can decrease the incidence of nosocomial infections. And we know that nosocomial infections is one of the biggest uh, predisposer to developing antimicrobial resistance. So when we say infection control, what exactly do we mean? There are three main components which are there in any ward, ICU, etc. You have a patient, you have the worker, which are the green dots, and you have the visitors, which are the blue dots. So what happens is there are usually, obviously, the healthcare workers are much more than the patient, and there are few visitors, so there are less blue and more green. So, as infection, a healthcare worker can take the infection from one patient to the other patient when traveling, because microbes are in the air, and in case proper hygiene is not adhered to. Similarly, a visitor can take when a visitor goes to one patient and then to the other patient, infection can go. And a healthcare worker again from one to the other, it can travel. So it's a cycle of patient to worker to visitor to patient, whichever way we put it. It's just a cycle which can go on. Or if you look at it in another way, there is a, let's put it this way, that we all know there are microorganisms in the hospital environment, and transmission of pathogens between staff and patients and among patients, like in the slide I just showed you. In oncology, we know all our patients are immunocompromised, so an interplay of all these results in a nosocomial infection. Right. So why do we talk about infection control? It's simple, we don't want it. So as per literature from the western parts of the world, it says that the prevalence of hospital-acquired infection is about 9%. There is no pakka data available in India, but we presume some small places have said about 10 to 20%. So let us, even if we go at 10%, it's a lot. And hospital-acquired infections contribute to antimicrobial resistance. So all of us know that in the past few years, it has become very difficult sometimes to counteract when we get a resistant organisms. Till a few years ago, we were very happy there was meropenem. Carbapenems got rid of all organisms. Then we got resistance to carbapenems. Then we were happy that yes, there is colistin. Colistin attacks them and they die. But now colistin resistant organisms are also there. And now we are again struggling that, okay, what new antibiotics is there? Because there is no new antibiotic. And essentially, it is because of too much use of antibiotics that organisms are becoming resistant. Organisms don't like being killed. COVID does not want to be killed. So whenever we are using antimicrobials again and again, organisms mutate to make sure that we can't kill them. And the other most important thing is poor infection control practices, which results in spread of infection. So, when we say we want to do infection control, what exactly do we want? We want to improve patient outcomes. Naturally, the patient will not stay in hospital, will not have too much infection, improve patient safety. No one wants to get infections one after the other. Reduce resistance. So, we will use less antibiotics, and automatically that will cut short our problem. And the whole thing will result in a reduction in healthcare costs. Less antibiotics, less hospital stay, less other things in hospital which are used. So automatically your cost will come down. So now when we say hospital acquired infection, which are the most common sites? We all know that surgical incisions, if a surgery site is not looked after properly, urinary tract, essentially any place there's a catheter, we can get an infection. And urinary tract is much more common in adults because very frequently when they're unwell in ICU they are catheterized more frequently compared to children, especially geriatric age group. Lower respiratory tract infection, children are lying down all the time when they're sick, or if they're on a ventilator, ventilator associated pneumonia is frequent. And bloodstream, which often is catheter related. So, coming to the epidemiology, right? The common microorganisms which we know are aerobic gram positive, which is Staph aureus is the most important, which is very often methicillin resistance is a big problem. It can go up to 30% in lots of centers across the country. And the other worrying one is enterococci, which is vancomycin resistance and creates a problem. And the other are the gram negative bacilli, E. coli, Pseudomonas, Enterobacter, and Klebsiella. Across the country these days, these organisms are getting scarier and scarier day by day as they are developing resistance to each and every antibiotic which is there. So, the root cause of infection is lack of training in basic infection control. Quite a few of us, if we look back, we will honestly say that when we were studying in our basic bachelor's course, we were never taught about infection control. A lot of other things are taught to us: anatomy, physiology, this, that, but nobody tells us basic infection control. And the same applies till quite some time. And only recently, people have started thinking that yes, people need to be told about this. Lack of infrastructure and poor infection control practices. We will all agree that very often, sometimes there is lack of facility. We say there's lack of glove, there's lack of this. So there's not enough rooms available to do procedures. So it is never done in a very often not done in a super sterile manner. There are inadequate facilities and techniques of hand hygiene. Yes, we have to thank the pandemic for teaching us a lot of hand hygiene and making sure that plenty of alcohol rub is available. Otherwise, even I know that very sometimes we could not find soap or soap had finished, and we were told that it's just soap has finished in the ward, so we manage without soap. And this is will happen much more so in smaller hospitals which are not in the larger cities because of lack of infrastructure. And yes, there is lack of isolation precautions and procedures. Certain things which require procedures, precautions to be made in total isolation very often is not done. Lack of knowledge and lack of other things being the main reason. So, carrying on, also we have to remember that now we use a lot of advanced and complex treatments. And this is very frequently done without enough training and supporting infrastructure. You know, we want to start a new therapy, a new surgery, something new which involves everything which is new and more advanced, is more complex. You need more invasive devices, etc. And you may not have sufficient doctors, staff nurses, and other healthcare personnel in the ward, but we want to start it. And sometimes there's a lot of pressure that yes, we must start doing something new. So that, because we do not have sufficient backup, will predispose to a infection. So invasive devices and procedures, we put in a lot of central lines in the ward. We have, let's say, 20 children in the ward with leukemia and other malignancies, everybody has a central line, but there are only two nurses. We cannot expect the nurses to manage. There's only one doctor. How will that do? Complex surgical procedures, intravenous catheters, fluids, medications, catheters, ventilators. We cannot run an ICU unless we have sufficient staff. So if we do it, yes, we are predisposing patients to get sepsis. Okay. And yes, of course, the most important is that very frequently there is inadequate sterilization and disinfection and inadequate cleaning of the hospital. Possibly in the last few years, the Kayakalp program has helped ensure that hospitals are clean. All of us will agree that the larger tertiary care hospitals are very often very clean, and we will also agree that certain small civil hospitals in the smaller towns can are not up to the mark. So what do we need? It's simple. We just need simple core strategies for reducing the risk of nosocomial infections. So there is a gap. There's lots of gaps. We all know that. All of you will think that, oh gosh, it's so easy to talk, but it's not easy to do. Nothing is easy to do. So the gaps, what we've said, poor or absent infection control practices, especially in the intensive care areas, can result in transmission of antibiotic resistant bacteria. Resistant bacteria automatically promotes even greater antibiotic use by the physician, resulting in antimicrobial resistance. So it becomes a catch-22 situation. Perception of knowledge by healthcare workers of poor sterilization, disinfection, or patient care practices prompts increased antibiotic use. So, you know, or there's the audience is nursing staff who knows everything very well, and I'm sure all of you will agree that sterilization, disinfection, you have the health assistants or the workers in the ward very frequently do not understand the importance of doing it properly. I have seen in our daycare, they will, the person who cleans the floor will not clean the tiles on the side because he says that is somebody else's job. So the tiles they will clean, they will forget to clean the fridge because they don't, surface of the fridge, because they don't understand, which is essentially because we have not taught them that all this is important. Then what we said earlier, what are the root cause? The root cause is lack of training, lack of a basic infrastructure and poor control practices, inadequate facilities and techniques. So, with the clean hand campaign and all this, everybody has learned how to wash their hands. 15 years ago, when there was no clean hands campaigns, a lot of people hardly ever washed their hands. People just put them under water and that was it. So, after the infection control committees were put in place, so everybody realized that no, this is important. And like I said earlier, lack of isolation, precautions, and procedures. You know, you will have a procedure room and two or three procedures may be going on at the same time, which is not appropriate. A person who may need isolation may not get isolation, or the person may not be aware that this needs isolation. So, all that can result in problems. So, going on to the other gaps, diagnostic, there's a very high burden on infectious diseases. We are a tropical country, and tropical countries have a higher incidence of infectious diseases. Often, we do not have sufficient diagnosis. We can have a blood culture, we may not get a report. The supportive care, for example, for fungal infections, we may not have the wherewithal to be able to do all other tests to help diagnose infection. There's less of knowledge and awareness. There's access to quality assured antibiotics is poor. We know that we sometimes do not get the best antibiotics. I have had patients telling me once in a while कि हमें अच्छा वाला एंटीबायोटिक लगाना, वो सस्ता वाले से बुखार ठीक ही नहीं होता, right? So we know that yes, approximately 25 to 30% drugs available in the market are not up to the mark. That is nothing we cannot do. I mean, we can just try a little bit, but we know that is a fact. Healthcare facilities. There's lack of basic infrastructure and equipment in a lot of hospitals. Some of us are very fortunate to be working in hospital where everything is available and it's good. But there are a lot of us who do not work with such good infrastructure, and we have to cope with large patient numbers, shortage of doctors, nurses, other staff, poor job satisfaction, Very frequently, some of us will be in a position where you had to put 2 to 3 patients on each bed, and we all understand and appreciate that that is not in the best interest of a patient, but there is no choice. So, a poor healthcare person is sitting and he has to cope with so much. He is told all the time, we are battered. Look after hospital acquired infection, nosocomial infection. This should increase. Antibiotic resistance. Please clean your hands. Keep washing your hands. Wear your gloves, mask, gown. And in the COVID pandemic, we've been going around with a mask stuck on our face for 1 year now. Clean, disinfect everything, do it frequently. Infection control is very important. So the poor fellow is trying to, all of us are trying to figure out, okay, I'm just one. What all can I do? But whenever we think, there are always solutions to everything. When we put our minds to it, we think, yes, there are solutions. What are the solutions? So, infection control committees have been instituted and they are there in quite most larger hospitals. And these were not there, let's say, 15, 20 years earlier, or the other way is that they were there, but they were not so aggressive. The idea is to prevent the spread of infections. They address simple things like food handling, laundry handling, cleaning procedure, visitation, and direct patient care practices. And the most important is they maintain, manage. You have to know the bacteriological data of the hospital and information, and also do surveillance to know what are the bugs troubling this hospital at this point of time. So once you know what is happening, the solution comes easy. Solutions are difficult when you don't know what is happening. When you know it, you put your mind to it. So an infection control committee will uh, develop and recommend policies and procedures to control infection. It will recognize and investigate an outbreak of infection in the hospital. For example, 3 years ago, a lot of children in our ward got diarrhea. So we were trying to figure out that how can everybody get diarrhea. So the infection control committee came and they went to check. They swabbed everything, cultured everything, and they found an infection was coming from one of the taps, which was looked into. They intervene directly to prevent infections. So they give talks, they do a lot of things. They have infection control nurses who come and do it, and educating and training healthcare worker, patients, and non medical caregivers. This, to my mind, is the most important because once you educate the community, you educate everyone. Sorry, just a minute. Yeah. So this looks a little busy, but I'll just tell you in brief what it means is that you have to, uh, you know, uh, attack all three areas. One is you have to attack your antimicrobial use. Be very careful that which antimicrobial am I using. Okay. Then you have to infection control. The most important, we all agree, hand hygiene, look into the epidemiology, outbreak, active surveillance, and your environment, which means your surface cleaning. Make sure the place you're living in is totally clean. So these are just the three things which are required for uh, infection control. So this, once you know what you're battling, the strategy comes in automatically. So, whenever possible, avoid crowding wards. Yes, easier said than done, but we still have to put in efforts. So, patients who have communicable diseases, right? For them, we have to make sure they're either in private rooms and wards with specific diseases. Naturally, if somebody has diarrhea, it's better they are separate. Visitation policies, relatives have to be curtailed. Yes, uh, we have in India, we have culturally, it's very good that we have a lot of relatives and all who come when a child is unwell. However, we also appreciate that we cannot have six people rolling at one time to see a patient. So this has to be strict. Hand washing, gowns when needed, masks, eye protection, and precautions with sharp instruments and needle, which this audience knows very well, and I don't have to go into detail in that. We have to ensure a clean environment, which means that yes, we make sure that there's procedures to prevent food and water contamination, regular schedule of hospital clinic, with appropriate disinfectant, not once a day. We all know hospitals need to be cleaned repeatedly. Medical waste is safely disposed of, and isolate soiled linen from normal hospital other uh, waste. This has to be done separately. So again, we need written policies and procedures are required. Otherwise, it is not easy to do. All objects are disinfected, sterilized, quality control. We make sure this is done properly. Once an item comes back sterilized, it has to be stored in enclosed areas. And single use items like disposable needles and syringes must be disposed of appropriately and not reprocessed. A few years ago, we used to be told that when they're just thrown away, they're taken from there, people boil them, and they're reused in the smaller villages and smaller areas, which we know is terrible. And hepatitis B and HIV are the two major worrying illnesses which can then spread through by the use of this. Okay. So, going on to the other strategy is sterile invasive procedures and IV medications. This is a little important, especially for all of us. Why? Because we use a lot of intravascular devices. We know in oncology we need a lot, we use a lot. So, but sometimes we forget we use only when necessary. You know, a lot of time a child is drinking very well, is sitting happy in bed, and then someone has put it on intravenous fluids. And then you say, no, if he's eating and drinking well, why have you put him on intravenous fluids? It's just there. It was a routine. Yes, silicone and polyurethane catheters have a lower risk of infection than the simple polyvinyl catheters which are available. Agreed, they are expensive and this is easily available, but it's something to know if this is available, we need to use those. Procure, prepare, and administer IV medicines and fluid in a sterile manner in a proper uncontaminated area with specially trained staff. This, I need to stress on this. This is a total nursing area, and very often we know that people make an error. And even now, when you have plastic bags, PVC bags, etc., even then people stick a needle in sometimes the cannula is left open. These tiny things are sometimes left out, which all of us know, but it just happens that when we are doing it, kind of gets left out. Fluids when required, and these days 100 ml bottles are very easily available. So one must remember to use IV antibiotics, etc. in that. Never, ensure it's a closed system so we do not have to poke any bottle the second time or do anything which will hurt it. I'm just repeating what all of you know. Similarly, avoid indwelling catheters whenever possible and remove as soon as possible. Right? So, if you have a urinary catheter, a chest tube, anywhere, as soon as a child is well, patient is well, it should come out. Right? The last part, the most important is, sorry, hand hygiene. Yes, we know it now. I'm not going to go into this. And like I said, the COVID has taught us that hand hygiene is so important. We have to ensure sink, clean water, and soap, alcohol rub at all locations. And this, if everybody starts washing their hands, there will be no issue. It is important to monitor compliance. ठीक. When we were a long time ago, we realized that the CCTV near the sink was actually near the head of the department's connected to the head of the department's office, and he used to look from there to see if everybody is washing hands or not. That time we were totally shocked that, oh gosh, he's spying on us. But now you realize that yes, it was basically to see, if we were doing complying, and it was hand hygiene practice. The effect of antiseptics on colony count, we all know you use alcohol, iodophos, and chlorhexidine, and all of them last for a few hours. Chlorhexidine lasts longest, but it may not be so easy to get. So, this tells us that yes, if you use hand scrub, your colony counts remain low for a minimum period of about 2 hours. And when we're in the ward, a hand scrub will be used much more frequently than 2 hours, and that in itself is the biggest thing which we can do for precaution. Your food and water precautions. Food, water supply occurs. We have to ensure that that remains straight. inadequate cooking. That is why we always tell parents and the hospital where the food comes from that it is always freshly made. Food handlers, the one who are making food in the kitchen, they may have an infectious disease and may not tell and keep coming. That has to be ensured. So, every hospital will have a policy and procedure to prevent all this contamination and make sure things go well. Now, everybody's going to think that, oh dear, this sounds like so boring and we can't do all this. How are we supposed to do all this? This is not my job. Everybody else can do it. Who's going to look after the kitchen? Who's going to look after the ward? Who's going to look after, the surfaces being cleaned? There's an opportunity everywhere for everyone. Simple things which can be done day to day by every healthcare worker, which is doctors, nurses, the people working in the ward, in the absence of an infection control committee. CVL site care, all of us, especially in oncology, we have CVLs, and that site care can be done. There's usually a nurse in places which use it. If it is not a central venous line, a cannula. Whenever you take rounds, one can just, it takes 10 seconds to check that it's not dirty and it's clean, right? Clean hands, we have know enough about that. We can all do it. Patient education, not when we are when a patient is being discharged from the ward, anyone, be it the doctor, the nurse, even the safai wala, even the can just or the ward boys can just tell a patient कि हाथ साफ रखने हैं, अच्छा खाना खाना है, पका हुआ पानी साफ पीना है. Three things can be told to them. We are not talking rocket science. IV access site I mentioned along with CVL site care. We have to make sure it's clean. Very frequently the bandage will be dirty, etc. It is our job to make sure that remains clean. Safe food and water. Food, simple, it should be cooked, not kept for more than 1 day. And water, we tell parents कि रोज 2 bottles of water can be boiled and kept for the patient if they do not have, because right, buying water may not be very easy for every family. Every family can boil water. And audit, it's, we talk about things, but how do we know what we're doing is effective? An audit. So if we, for 6 months we put into practice something, and at the end of 6 months we say yes, this has made a difference, and that can only be done by audit. Collect data. We cannot come to any conclusion or move ahead if we do not have data. So that is important. Empowerment means that so many people can do all this. It is not only for one person. The head nurse in the ward, she can empower the ward boy to do a simple thing like every day when he's cleaning the ward, to tell patients two small things: that have safe food, have safe water, right? Take a bath every day. Tiny things can be done. We empower people. So if someone is given a responsibility, the person will do it. If we do not give people responsibility, the person will say, okay, why should I do it? I've not been told to do it. Simple. And all this, if we do an audit, collect data, we will know when there is improvement. And most important, we have to remember to felicitate. If someone has done a job well, if there has been a nurse in the ward who has looked after her IV sites, done things excellently, she can get the Nurse of the Month award, Ward Boy of the Month award. Very often we forget to thank or appreciate what a person has done, which sets back a person. It doesn't give the person motivation. So we have to remember that is an important thing. We can fill in the gaps by you doing small things. So every gap can be filled in if we put our minds to it. Nothing is insurmountable. So summarizing, I'll say that infection control procedures are vital to prevent nosocomial infections and ultimately control hospital costs. Simple, inexpensive strategies can prevent many infections. In my previous slide, the opportunities, they are all simple strategies. If we put them in practice, everything can. Each one of us can support. Many infection controlled activities, and the most important are hand washing, using appropriate antiseptic and disinfectants in the ward, making sure everything is clean, monitoring IV and injection preparation and administration because sometimes there can be problems there. And so, infection control programs, when put in place appropriately, reduce the spread of infection, and ultimately, this will decrease morbidity and mortality because that is the worrying part about nosocomial infection. Maintain employee health and morale, decrease the incidence of antimicrobial resistance, and ultimately, this will result in a decrease in health costs. And I thank you all for a very patient listening.